Hello everyone, welcome to sqadia.com. My name is Imran and today we will talk about musculoskeletal imaging. So musculoskeletal is a broad term. It's an entire domain and an umbrella domain, that is, because it involves all the muscles, all the bones, all the intra-articular structures, everything that is between two bones which are forming the joints, the bursas, all the ligaments, tendons, as I said. So all of these structures fall under the domain of musculoskeletal system. So obviously, when we talk about musculoskeletal imaging, we are going to talk about all of these structures and how they appear on radiographs. So let's begin. So the first section of this lecture is musculoskeletal imaging requisition. So we are going to, in this section, discuss the requisition form. So this is how the requisition form appears. And so X-rays, we're going to talk about X-rays and ultrasound. So X-rays, you can demand an X-ray when you walk in the X-ray department, and on point there can be an X-ray on point on the initial walk-in time. So there are depending on the different body parts, there are different views of X-rays. So for example, for abdomen there is a KUB, which is the kidney, uterus, and the bladder view. So these structures can be viewed in X-ray abdomen plane. And in acute conditions, there are three different views which are usually demanded: the AP, the PA, and the lateral view. So to understand the different views, we need to understand the basic physics of the X-rays, or the different components of the X-ray machine. So there is a component known as bucky, or the X-ray cassette, upon which the X-rays hit after passing through the body part or body segment. So that is behind the individual, the entire individual or the body part that is being viewed. So that is basically a cassette in the component of X-ray, the entire X-ray modality, and it is called bucky. Bucky contains the cassette, and obviously there is a generator which generates the X-rays which fall onto the body and exit from behind the body onto the cassette or the bucky. So the views of X-ray depend on the orientation of body with reference to where from where the X-rays are coming. So if the X-rays are coming from this direction, and this obviously being my anatomical position, anatomical interior position. So if this is subjected and facing towards the X-ray generating site, then the X-rays will come and fall on this anterior surface and exit my hand or any body part which is being viewed, and exit the posterior surface and fall on the bucky or the cassette, which will form the entire radiograph. So this will become the anterior posterior view, the AP view. If the posterior surface of my hand is subjected to X-ray generator, and is facing the X-ray generator, then the X-rays will first enter my body from the posterior side of my body part or my body segment or my hand, for this example, in terms of this example, and exit my anterior surface and fall on the bucky. So this will make a posterior anterior view, which is PA view. And then the lateral will be if the lateral sides of my hand or body segment or body part are subjected or are facing the X-ray generator site. And if they first enter my body through the lateral surface and exit through this surface, then it is a lateral view. So this is the basis of views in X-rays. So X-rays can depend on the views depend on the body segments. So there can be oblique views, there can be some special views and special standing position or sitting position or body positioning depending on the structure that is to be viewed. So this is a chest X-ray. So the best view for chest is the posterior anterior view, in which your face is towards the cassette or bucky, and the X-rays are subjected to your body and entering your body through the posterior surface and are exiting your body through the anterior surface. All the body segments are written in this form, and the right and left obviously being the extremities are right and left on, so these can be checked, these boxes can be checked, and this form is the entire X-ray of every body segment: the head and neck, the abdomen, chest, spine, skeletal surveys. Skeletal surveys are basically X-rays of the entire body, which is to rule out some arthritic changes, which can be RA, OA, which is rheumatoid arthritis or osteoarthritis, and other types of arthritis as well. There can be infective arthritis, which is visible on every radiographical modality because they are very massive. Metastatic series, if it is depending on the stage of the metastatic activity or the metastatic stage, depends on depends on the stage, the area involved, or the bone involved, or the intensity of involvement depends upon the stage of the disease. So metastatic series is basically to rule out any cancerous involvement, or to rule out any cancers in the entire body. So for the upper extremity, all the joints, from the joints in the hands, the bigger joints, the glenoid and the humeral joint, that is the shoulder joint, the radius ulna, all the joints, all the bones, the shafts, the epiphysis, all are viewed, and this is the form, depending on what segment, body part, or structure is to be viewed. So ultrasound examination is very good if we are expecting some rupture in the tendon or ligament. There is good visualization. So when we talk about X-rays, we use the terms of opacities and lucencies. When we're talking about ultrasounds, we use the terms hyperresonant or hyporesonant. So X-ray image is formed when the X-rays actually pass the body and are absorbed, either absorbed by the body or are absorbed by or fall on the cassette. So ultrasound images are formed when the sound waves hit the body and they resonate. They come back to the probe, and the image is then formed. So the sound waves actually hit the part which is to be viewed in an ultrasound. They come back, hit the probe, and the image is formed. So this is appointment based, because there are different days depending on the body segments. There are days for the ultrasound. So normally to get an X-ray, you do not require an initial appointment, because X-rays can be done on the entire body, and no special technique is required. But for ultrasound, there are different people which are more equipped with assessing or examining different body parts, and their ultrasound examination can be done by appointment, on appointment basis. So we talked about all of these: abdomen, chest, spine, and all of these segments can be individually X-rayed. For extremities, it is very important to do a comparative analysis for a better diagnosis. So if you are expecting, for example, if you're expecting a fracture in the right arm, it is better to ask for an X-ray of the left arm as well, just for a comparative analysis, because there are sometimes hairline fractures and some other sorts of abnormalities, some deformities, which can be ruled out if two extremities can be compared. So this is that. And then ultrasound, depending on the body parts being viewed on ultrasound, there are different days, mostly in the ultrasound departments. Then musculoskeletal ultrasound, like I said, musculoskeletal ultrasound is very good in ruling out any tendon and ligament injuries. X-rays are the first line of imaging, or the first recommendation if there is suspicion of any musculoskeletal lesion or abnormality. For specific structures and specific abnormalities, ultrasounds can be, an individual can be subjected to ultrasound examination. Now we move towards the fracture classification. So fractures can be classified on, like I said in the introductory section, the fractures can be classified on numerous bases. But here we're going to talk about the Salter-Harris classification, which is a classification for young children and their fractures. So what happens, obviously there are differences in an adult bone and the bones of young babies or some young children. The differences are, for example, the periosteum in the adult bone is a thin layer, whereas the periosteum in young children and young children, in babies it's a little bit different, but in young children the periosteal layer is very thick. So the probability of a complete fracture through and through the two sides of the bone is it's very rare to see a child with a through and through fracture, because the periosteal layer is very thick. So the bending of the bone is more probable under stressful condition in a child. But an incomplete fracture results, which is also known as a Greenwich type of fracture. So Salter-Harris is actually the fracture classification of the physis, the growth plate, the epiphyseal plate, whatever you call it. So the fracture of the growth plate in young children is classified on different types by Salter and Harris. So we're going to talk about that. So this is the epiphyseal plate. The epiphyseal plate, or the physis, or the growth plate, is responsible for the longitudinal growth of the bone. So because the bone is not susceptible to shaft fractures, because like I said, the periosteal layer is thick, if there is a very intense or stressful condition, the resultant fracture is probably going to be an incomplete fracture or a Greenwich fracture. But the epiphyseal fractures are common in young individuals or children, for that matter. So this is the growth plate. And the first type of fracture is the fracture that involves only the growth plate. So it's a through and through fracture, but it involves only the growth plate or the physis of the bone. The second type is involving two parts of the bone, the neck or the metaphysis, and the growth plate. So this fracture is through and through in a straight line. This fracture is also through and through, but it is going from the growth plate to the neck. So the fracture which is from the epiphyseal plate to the metaphysis and going in this direction is type 2 Salter-Harris fracture. This is the third type of Salter-Harris fracture. So what happens here is that this involves the first the growth plate and then moves towards the epiphysis. So physeal fracture starts with at the physis. So it's a physeal fracture moving to the epiphysis. This is a physeal fracture moving to the metaphysis. So this is the third type. And then this is the fourth type. This type involves the growth plate, but is a fracture that moves from the epiphysis through to the metaphysis of the bone. And this is the fifth type. This is due to the compression, due to some compression injury or compression stress to the bone. And this, obviously, this is through and through, but this is different from the type 5 Salter-Harris classification is different from type 1 Salter-Harris fracture, because this is due to the mechanism of injury is different. So the compression will always result in this type of fracture. So obviously the history will play a part in differentiating between type 5 and type 1. So now let's move towards the incidence of these fractures. So type 2 is the most common, being at 75% of all these Salter-Harris fractures, or the physeal fractures are actually type 2 Salter-Harris fractures with an incidence of 75. Then we have this type 4, 10%, type 3, equivalent chances of both type 4 or type 3 fractures with 10%. Then the chance of the type 1 Salter-Harris fracture is 5%, and the incidence or the percentage of type 5 fracture is currently not known. But these are usually rare. Most common is type 2, resulting from a fracture that moves from the physis or the growth plate or the epiphyseal plate towards the metaphysis. So all of these fractures are through and through fractures. It is important to remember that these are in children when the growth plate is present, which actually is not present in adult life or adulthood. So now we move towards the fracture classification, some other types of classification, and we're going to talk about that. Let's go to the image directly. So this is the first image. Before going to the type of fracture or where the fracture is, let's just talk about this and where everything is in this radiograph. So this is the view of, this is an X-ray view of the forearm and hand of an individual. So the hand, the bone of the forearm that is related to the thumb or is towards the side of the thumb is the radius, and the next to it is ulna. So this is radius and ulna. These are the carpal bone, the metacarpal bones, and the phalanges. So where is the fracture? This is actually the fracture site. Okay, so how do we know what the age of this individual is? So the ossification of bone is, the age is actually a determinant of the ossification of bones. So there are specific age brackets that are given for every bone which is completely ossified at that age. So these carpal bones are not completely ossified and are not completely bony in their anatomy on the birth of a child. So in the growing age, it takes about 12 years for all of these carpal bones to appear. And obviously we can also see these growth plates, and these are not ossified as yet. So this is the capitate, which is the first to ossify, and the last to ossify is the piriformis, which is not present here. So this is the X-ray image of a child which is probably below the age of 12, actually at the age of 6, because there are 5 carpal bones which are which are actually ossified and visible on the X-ray radiograph. So this is scaphoid bone, the capitate, which is the first to ossify, hemate, and the small ossification centers are have appeared here: scaphoid, lunate, and tricutrium. So scaphoid, lunate, tricutrium, capitate, and hemate. These have ossified. These are 1, 2, 3, 4, 5. These we can look at them and determine whether this is a child, or actually for every radiograph there are different indicators of the age. For example, if we're looking at the pelvis radiograph, we can actually determine if that is an X-ray image of a male or a female, depending on the different radiographic identification points that are visible on the X-ray. So now that we've determined that this is a child's X-ray, let's actually focus on the fracture. Like I said, in children, the complete fractures or the incidence of complete fractures is actually very minute. The percentage is very small, and it's actually rarely seen to have a through and through and complete fracture unless it's a physial fracture or the growth plate fracture. So this is an incomplete fracture, which is also called the Greenwich fracture. So this is not through and through, just a small portion, or the 2/3 as is visible here is involved in the radius. So this is a fracture, the radius. This is distal radius fracture. Proximal to the center is so close to the center is called proximal, and the away from the center of the body is called distal. So this is a distal incomplete fracture of the radius bone. This is obvious, everybody can probably identify the fracture here. So now we can also, before going to the fracture, all of these carpal bones are visible here. No growth plate is visible here as was here. So this is an adult adult hand, an adult forearm. And what is present here is a fracture of both the radius and the ulna. This is radius, this is ulna, and there is complete fracture of both the bones. Excuse me. So this is a radiograph of the lateral view. This is the lateral view of the leg, and this is the PA view of the leg. Okay, this is the calcaneus, this is the tibia and the fibula. Fibula is the lateral bone, tibia is the medial bone. So the fracture is here in the fibula. It is a linear transverse through and through fracture, which is also visible in this view, this lateral view. Okay, so let's now talk about this. This is the radiograph of the foot. And this is a sort of like an oblique view of the foot, and the focus, this placement of the foot is to optimize the area of the foot that is to be visualized. So the positioning of the body segment or body part is actually in accordance with the structure that is to be viewed, right? So because here, which in this radiograph, the main reason for this radiograph is actually to view this portion of the foot, right? So the focus is to make this little finger more prominent. So the placement of the body part or segment is in accordance with the structure that is to be viewed. So here this is a linear spiral oblique fracture. So this is a linear fracture, but this is an oblique, probably because of some rotation of this bone. This is the fracture here, and it's also visible here. So this is a spiral oblique fracture. This is a radiograph of the forearm. and the fracture is here. So this is a comminuted fracture, which means that this is in different, so this is a lot of different fragments of the bone can be visualized here. So this is depend on and different sizes of fragments. This is a very little fragment. This is a comparatively bigger fragment, and there are probably multiple spurs, bony spurs here present in this fracture site. So this is a comminuted fracture type. This now here is a radiograph showing the segmental fracture. So segmental fracture is when the fracture is such that there is an entire segment of the bone that is now not in continuation with the entire or the rest of the bone, right? So this entire segment is no longer in this entire shaft of long bone. It's actually a fracture of both the tibia and the fibula, but the fibular fracture is not a segmental fracture. It is just a complete through and through fracture. This is a linear fracture of the fibula and a segmental fracture of the tibia. So this is the radiograph of the leg from the knee to the excluding the ankle. So these are the two fracture sites. Here, the fibular fracture can be visible as well. Here, you can also really see the fibular fracture, but it's better viewed in this view. Okay, so this is the radiograph of the foot, and here again, the placement of the foot is such that this portion of the foot can be identified or be clearly seen. So the placement, like I said, is very important and in the diagnosis. And if the radiograph is obtained with improper position, it is very difficult to make a proper diagnosis. So placement and the views which give optimal visualization of certain structures should be memorized and should be known before ordering a radiograph. So this is the avulsion fracture. What is an avulsion fracture? It's basically when the bone fragment is fractured through and through. So, but this is pulled away from this shaft of or the rest of the bone because of the tendon that is attaching at this site. Because the tendon is attached here, and there is obviously a tension in the tendon. Tendons are tensed and they are pulling the bone. So this segment is going to be pulled away from the rest of the bone because of its attachment to the ligament. And this results in the avulsion fracture. So in weight-bearing position, this will be very painful. So normally every fracture is from hairline to comminuted to segmental is a very painful condition, but this in weight-bearing will be painful, and without weight-bearing, this is probably going to go unnoticed. So there are cases in which athletes come with avulsion fractures, and after fall, which resulted in some avulsion fracture here, they actually are capable of completing their race, and these symptoms are present, but they are mostly, the pain is not as severe as it would be in other fracture types. So now this is the hairline fracture, which is very easily missed on radiographs, but on CT scan it is still very it still shows a very good visualization on CT scans. But hairline fractures are usually missed. So the fracture here is this line, and here this line that is going. So this is the fracture. So hairline fractures are easily missed on the radiographs, X-ray radiographs, but the placement of the patient or the individual who is being X-rayed is an important determinant of whether the hairline fracture will be visible on the X-ray or not. So the placement is very important. Now we move to the third section of the lecture, which is healing of the fracture. So after fracture has resulted, there are a certain sequence of events that takes place. So first, this is the acute condition when recently a fracture has occurred. So what happens is that here a lot of blood has accumulated because of the disruption of these vessels. So this blood flow has been disrupted, and obviously the blood has accumulated here. So this is known as hematoma formation, or also like a clot is being formed here. Blood is accumulating here. So this is the second sequence event that is next to or after the hematoma formation, which is fibrocartilaginous callus formation. So next is that the fibrous cartilage and as well as the inflammation that was here resulted in the as a result of the acute injury has subsided somewhat, but there is still some inflammation here, but the overall inflammation has somewhat subsided. So this fibrocartilaginous callus is being formed, which is a cartilage which is not bony in anatomy or the in composition. It is not bony, it is fibrocartilage. So what happens next is the ossification of this bone. So this is somewhat similar to the bone of a newborn baby, or when the bone has not ossified. So this is bony callus. The bone is ossifying. It has not completely ossified as shown here, but it is ossifying, and the integrity of the bone is maintained. So an important thing to notice here is that this disrupted blood flow has been continued here by the process of angiogenesis, obviously. So the angiogenesis process is a part of fibrocartilaginous callus formation. So in bony callus formation, all of this fibrous cartilage actually starts to ossify, and this is now turning into the bone, and so the composition of the entire bone is similar. Here, the composition of the entire bone is similar, but there is always going to be some anatomical difference after the fracture, even though the bone has completely reformed, is completely remodeled, but there is always going to be some differences, some changes in the entire continuity or integrity of the bone. So the normal healing process is said to be 6 to 12 weeks, but it can take longer and there can be some complex conditions in which there has to be some surgical intervention to promote the healing process if the bone segments are very far away from each other, or if there is a comminuted fracture or if there is a segmental fracture in which the segment of the bone that is fractured is not in its anatomical position, is not upright, or is not continuous with the respective bone parts. So all of these factors determine the amount of time that will be required for the optimal or the complete healing of the fracture site. So this is the healing of fracture on an X-ray. We will first look at the day 1. So this is the fracture site. This is the fracture. These are actually overlapping. This is probably one surface is pointing anteriorly, and the other is probably directed posteriorly. So this is why this overlapping is visualized or is visible here. Oh, right. So see, this is anteriorly has moved or displaced anteriorly, and this part of the bone has moved or displaced posteriorly, and that is why in this view they are seen overlapping, right? So this is the week 1 So they have not really there is still inflammation. Inflammation is visible on the X-ray. There is hematomas can be visible. Inflammation is actually visible. So the surrounding tissue can be identified as inflamed on even on X-ray. So 1 month. This is actually the fibrocartilaginous structure, or the fibrocartilage cartilage that has formed here. This is 1 month. So in 6 weeks there is a somewhat ossification of this cartilage, fibrous cartilage that is visible here. So there is some ossification of it in 6 weeks time, and in 10 months it has completely healed. So there is no visible disruption in the integrity of the entire bone when the same individual has been x-rayed on a different occasion in different time series. So after 10 months, the bone has completely healed. So this is how the healing process is visualized on X-ray. So this here we can see the callus on the radiograph. This is the humerus, the glenoid fossa, the scapula, ribs are visible, and this radius and ulna. So here the callus formation is visible on X-ray. So basically the bones are not letting any X-rays pass through, and thus this appears as a very white, or like you say, very opaque. And this here lets some of the X-rays pass through and blocks the passage of some. So this appears a sort of like a grayish color, and this is very visible whitish color. So here too, this is the callus formation, which is a fibrous cartilage. Now we're going to talk about the fourth and the last section of our lecture, which is radiological features of degenerative joint disease. So a lot of changes occur when there is degeneration within the joint capsule. So we're going to talk about them step by step. So first is a very visible reduction in the joint space, which is an indication of some internal joint degenerative disease. So this is the normal joint space. As you can see, this is very optimally apart, and the cartilage is obviously present within, and there is an entire joint capsule which is not visible on the X-rays. So here we can see the loss of joint space. So there is narrowing of this space, which results in increased friction, and obviously increased friction will result in further damage. So this reduction in joint space results in increased friction, which results in increased damage, and this actually turns into a cycle. Then a lot of different other changes also occur with the joint space narrowing, like sclerosis, which we will discuss later on. And then obviously there will be some osteophyte formation, which all of this starts as a cycle. And the initial stages of the degeneration or any joint disease is the loss of this joint space. So the loss of this joint space results in the is actually a consequence of degeneration, and is also a participant in further degenerating the joint. So this is the second feature of degeneration in the joint. Osteophyte. Osteophytes are the bony spurs or pointed bony formations within the joint capsule. So this joint surfaces, the ones facing each other, if there is any bony spur, a pointed bony ridge here, that will damage the entire movement of the bone. It will result in restriction of the bone, obviously, and the continuous movement with a pointed osteophyte present within this joint structure will result in damage, inflammation, and obviously inflammation in the knee joint will itself cause a lot of problems, and the cycle will begin. So all of these actually contribute to degeneration themselves, as they are the consequence of degeneration and a participant in further degeneration. Like I said, joint space narrowing is the same as osteophyte formation, which result in further damaging. So when the knee will be flexed or extended, for example, the bony spurs or the pointed bony ends of the bone will irritate any soft tissue which comes between the two surfaces, all the cartilaginous structures that are present within. It will disrupt the entire flow of the intercartilaginous fluids, and all of those structures will be influenced and they will be further damaged, and the degeneration will obviously progress because of osteophyte formation. Then there is sclerosis of subchondral bone. So let's just first focus on subchondral. So chondral is cartilage and sub is obviously below. So subchondral is the cartilage that is present. So subchondral is the below the cartilage. So below this cartilage and above the cartilage are here. So this is the increased density. There is increased density in the bone tissue here. There is increased periosteal density here. What happens due to this increased periosteal density is that it increases the chances of osteophyte formation. And like we discussed, the osteophyte formation will obviously result in irritation of all the structures within the joint capsule. Another thing that happens because of sclerosis or this increased density of periosteal tissue here is that the joint space obviously will narrow as a consequence of this increased activity or increased accumulation of periosteal cells in this region. So if there is an increase or a decrease in the space here, or the narrowing of the space here, sclerosis will further narrow this space. So how sclerosis appears is this bright line that is visible on the x-ray. So these bright lines that are visible on the ends of the x-rays, on the ends of the joint surfaces on the x-ray, are indicative of some sclerosis of the subchondral bone, which is the bone next to the cartilage between the joints. So here also these bright lines are showing the sclerosis of bone, meaning that there is increased periosteal activity here, which will result in further narrowing of space, which can also result in osteophyte formation. So like I said, degeneration in the joint is a cascade of events. It's a cycle that one thing leads to the other. It is a result of degeneration and itself causes further degeneration. So it's all a cycle. One event when occurs in the degenerative process, the other is 100% chance of incidence of the other events. So here there is joint space narrowing. We can see sclerosis. So now let's talk about these loose osteocartilaginous joint bodies. So how are they different from the ones that we discussed before, the bony spurs that were formed here? These are out of the intracapsule, or these are not intracapsular. These are outside the joint capsule. So these can be any ossification of any muscle or tendon or ligaments. These can be present in any of these structures. These can be present in muscles. These can be present in tendons or ligaments. So these are just osteocartilaginous bodies that are not joined with, or are not continuous with any bone, but are present in proximity of any joint surface or any bone. So these are present here, 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 and this is actually in the intracapsule capsule. So let's just consider these as the loose osteocartilaginous joint bodies. So these can be seen in this view as well. So this is the lateral view of the knee, and these are the loose osteocartilaginous bodies visible here and here. So now let's talk about subchondral cyst, which is also a degenerative joint disease. So what happens in this is actually the acetabular fossa. This is the humerus and this is the pelvis bone. So what happens in subchondral cyst is there is massive degeneration due to a cyst formation within the joint capsule or in joint surfaces. This is very evidently visible or very clearly visible on the x-rays, and this disruption in the acetabular fossa is actually an indicative of this subchondral cyst. And the sclerosis is also present. There is narrowing of joint surfaces as well. So this was all for radiological features of degenerative joint disease. The subchondral cyst has been described here. We talked about sclerosis, joint space narrowing, osteophyte formation, some loose joint osteocartilaginous bodies. So that was it for today. I hope you liked it. I really like radiology. I hope I made it easy for everybody. So in today's lecture, we talked about the musculoskeletal imaging techniques, modalities. We talked about X-ray. We touched ultrasound a little bit. Then we talked a little bit about the requisition form. We also talked about the different classifications of fractures. We talked about the healing of fractures, and then we ended on the degenerative changes in the joint surfaces. So that was it for today. I hope you liked it, and to watch more videos on the radiology series, please visit sqadia.com. That's it for today. Thank you.